Today I'll be discussing about microsurgical skill training. Although extensive theoretical teaching program is made for a neurosurgeon, there is a need for more emphasis for practical skill training. Microneurosurgical operations are different compared to other surgical operations because of the longer operative time, usually the narrow and deep operative corridor, hand-eye coordination when microscope or endoscope is used, fine manipulations, more chances of physiological tremors, especially when the surgery is long. There is a need for proper understanding of the following things. We need to know about the hand support, physiological tremors, proper instrument design, development of surgical skill. We need to know the proper positioning of the patient, correct hemostatic techniques, tilting operative table, good operative microscope, adjustable chair, proper use of suction, bipolar forceps, and brain retractors. All these components are important in microsurgery. The other component of skill training program is we need to know about the various surgical grips. You need to have a stable and well supported body part during surgery. We should also understand what is the proper design of the instrument and use instruments with proper design. In the surgical technique, we have to understand the bimanual technique regarding the best use of suction, various hemostasis technique, brain retraction, proper ways for brain retraction, how to use drill, the ways to go for faster decompression of the lesion, how to do dissection. In the surgical technique, we have two grips. One is the precision or pen type of the grip, and the other is power or piston grip. So precision or pen type of the grip is preferred because this gives rise to better precision and it avoids fatigue, whereas power or piston grip, although is required when you need some power to break the tissue, but it is not precise. If you have to use piston or power grip in some surgical technique, you have to add the precision grip to do a well precise work. This is the example of precision grip or pen type of precision grip. It provides stability, and in this the thumb, index finger, middle finger are used as a tripod as shown here. Three fingers as tripod with ulnar side of the hand, wrist and the elbow are well supported. So well supported hand and these three fingers used as tripod. In pen type of the grip, there is a fine linear movement and rotation are performed using intrinsic muscle of the thumb and index finger. So only thumb and index finger intrinsic muscles are used, and there is very fine either linear or rotational movement, whereas the long flexor or extensor muscles of the hand are not used at all. So multiple long muscles of the hands involving multiple joints are not used in the pen type precision grip. This is the example of the instrument having pen type of the grip. You can keep your thumb or index finger on the designated part on the instruments. The other name for pen type or precision grip could be a quiet hand technique. In this, your hand should not be under any kind of stress, and the most of the muscles should be at rest. Only the intrinsic muscles of the thumb and index finger should be working. The long muscles are at rest. The least number of motor units are recruited to perform a task, as each contracting muscle fibers add to the tremor. The other grip is the piston or power grip, where there is a less precision compared to pen type grip. Hand cannot be stabilized on the operative area because of the type of the grip. The movements are at multiple joints, which involves hand, wrist, elbow, rather than the fine movement of the thumb and index finger. So therefore, there is a less precision. The long muscles and more fibers are recruited, which increase chances of tremors. But there are methods to improve precision in power grip. So whenever you are using power grip such as carries and punch, you should add some method to improve precision, and these are that you stabilize the hand either on the other hand or on your body part or the arm of the telescope holder or on the arm support. And when you are using power grip, then add precision grip by other hand. The other component is stable and comfortable body parts. Each part of the body should be in as comfortable posture as possible. Feet should be supported on the ground or footrest. Back, neck, and the head should be straight. Shoulder should be adducted. Elbow should be mildly flexed and supported. The wrist, hand, fingers also should be well supported. So these are the examples. The foot support, straight body posture, and the elbow and hand are well supported. Then you should also support and stabilize your hand and fingers on the seat. And here you see that in the craniotomy, the hand is supported on the skull. So surgeons should use some support or a bridge to avoid tremors and also to improve precision. These are some of the examples. The wrong way, unsupported thumb and index finger. So the hand is not supported. Here, there is a strain on the multiple joints of your hand. Whereas the other posture is the suction. In this position, thumb and index finger are supported by the other fingers of the hand, but these fingers are also under the constant strain. Less preferred, but there is some stability. On the other hand, quiet hand technique, in which the thumb, the index finger, these are well supported by the other fingers, and these fingers are supported on the surrounding operative area. Choose proper length of the instrument. If you use too long instrument which does not allow hand support near the operative area, so here the suction is too long and your hand is not well supported. On the other hand, if you are working in a superficial area, it is better to use smaller length of the instrument so that your hand is well supported. Surgeon's second hand fingers or the assistant hand can be used to support the long instrument with power grip. Here, when you are using a very long instrument with power grip, the assistant is holding the fine scissor. Surgeon's hand is using the precision grip and well supported hand, and then you can perform the surgery. Other hand fingers are used to support the long instruments. So this is the long carries and punch with power grip, and the fingers of the other hand are supporting the shaft of the carries and punch and to add precision. So use all 5 fingers of the hand for multiple functions. You can also stabilize your instrument on the operative corridor. This is the example. This is the opening. Your long instrument arm can be resting on the edge of the corridor. The summary of this is that support instruments and support all joints of your hand. You can consider that the instruments are also extension of your hand. So the instruments are also well supported, and your all joints should be well supported to add precision. Hand which is holding the instrument should also be well supported at all joints, and also fingers with movement occurring at the thumb and index finger. One should choose proper design of the instrument. Good design instruments are those in which proper design is used. Precision grip should be preferred for all delicate work, whereas power grip should only be used when power is required for particular work to be done. Poor design is one in which power grip is used in the instrument where there is a delicate work. These are the examples of good design. This is a Carrison punch. So the work of this Carrison punch is to break the bone. So you require power and there is a power grip. And this is also an example of a good design. This is a fine scissor and there is a precision grip in this instrument. So this is also good design, whereas this is a poor design. This is again a fine scissor which is used for cutting in the depth, but the design is poor. It is a power grip. This power grip does not allow good precision. So this is a power grip, whereas the work of the instrument is delicate and it requires precision. It is better to have an angle tip instrument as compared to straight tip for better visualization, especially when you are using a narrow corridor and you are using the endoscopic technique. Bayonet handles are preferred because the handle help prevent surgeon's hand from blocking the view in the operative area. On the other hand, straight instruments are preferred in the endoscopic size. Instruments with round shaft are preferred compared to flat shaft instrument because rotation is difficult when these are rectangle or flat, whereas round shaft instruments are better for rotation. Single shaft instruments are preferred in the narrow operative area compared to double limb instruments. This is the double limb instrument, bipolar forceps with double limb. This is the single limb bipolar forceps. So this will occupy less space. Sometimes more than two functions such as irrigation, suction, drilling, grasping, cutting, etc. are required in a narrow operative field where it is difficult to introduce more than two instruments. Grasping and cutting forceps can be combined in one instrument. Likewise, irrigation and suction can also be combined. Drilling and irrigation also can be combined. Irrigation and bipolar also can be combined. We can have the bipolar forceps and the irrigation combined. Professor Charles Tube instrument. The surgical corridor should be along the long axis of the tumor. It should be at 90 degrees to the floor, and you should rotate the head in such a way that the incision is at the highest point. To explain these things, we can take help of these two images. Regarding the corridor axis, it should be in the long axis of the tumor. If this is the tumor, this is the long axis. If you make corridor like this, then even with the small corridor, you can take out the whole tumor. Whereas if you come at other axis, right angle to the long axis or at some angle to the axis, then you have to retract more brain and may cause injury. Regarding the 90 degree to the floor, this is the example. If you keep your corridor 90 degree to the floor, then there is no need to retract the surrounding brain. Whereas if you keep it at some angle such as 60 degree or 45 degree, then the overlying brain will keep on falling to the corridor, and in the whole procedure you need to retract this brain unnecessary and cause trauma. Create large tumor into the small tumor before attempting to dissect the capsule. Otherwise, the surrounding vessel or the nerve, which is already stressed, may get injured and the dissection will be difficult. If the capsule is not separating from the surrounding tissue, most of the time it is due to the thick capsule. So decompress it further, remove more tissue. It will be easy to find the cleavage between the tumor and the surrounding vessel or nerve when the capsule is thinned out. Don't try to dissect the thickened ligament from flavum from the medial side when ligamentum flavum is already pressing onto the cord or the nerve. You will injure the nerve or produce irreversible deficit. First, either you decompress it, make it small, or come from more spacious area, which may be cranial or caudal. Come from below or above, and do not try to insinuate your Carrison punch between the already compromised nerve or the cord. The two limb instruments can be used as a dissector or as a retractor. This is the example, this is the tumor, this is the nerve. The two limb forceps can be introduced at the junction of these two structures in a closed limb position, and then you gradually open it out. And separation of these two limbs of the instrument also allows visualization in between these two limbs of the forceps. Introduce instrument at an angle to allow proper visualization of the instrument tip, or you should have the instrument with angle tip. If you are working in the superior direction, then you should try and introduce instrument from the inferior side. When you are working in a deep area and a narrow corridor, then the movement by rotation is better than the linear movement, because there is very small corridor, narrow corridor, so it may be difficult to go for linear movement, and use angle tip instrument so that you can reach at all the corners of the field. The angulated, flexible and 360-degree rotating shaft instrument can permit suturing in these long and narrow corridor. If you require suturing in such situation in a deep area under microscope or endoscope, then you can use through the loop technique for knot tying. Needle to needle holder angle should be 90-degree or little away from the needle holder. You can use J-shape needle for easy suturing, and needle holder tip should be slightly curved. In a deep and narrow corridor, the knot can be made outside the field, and by knot pusher you can push it in the operative area. First suture knot can be given at the beginning of the suture, and suction should help directing the needle tip and stabilize it. The needle tip should be directed towards the more spacious area. So you should plan beforehand that that will be the site of puncture, and in this direction I should be moving my needle for suturing. Keep needle on the dural margin, and again you go for rotating movement of the needle holder and not the linear movement if the space is less. The other trick to get more space for suturing is, if you are working through the tubular retractor, then in that case the tubular retractor or tube should be slightly withdrawn, so that you have more space and the tube wall are not coming in your way for suturing. The sliding knot technique can be used, and this is the example. The length of the instrument should be as small as possible for better precision, but if you are working in the deep area, then you need a longer instrument, but when you are working in the superficial area, then the shorter instruments are preferred. When you are going for dissection, you should use gentle traction and counter traction in the opposite directions. So this is the example. This is the tissue, and this is the nerve, for example. And if you want to separate this tissue from the nerve, then this is the wrong way. The suction is also trying to pull this tissue away from the nerve, and the dissector is also pushing it down. So both suction and dissectors are pulling the tissue away from the nerve in one direction, whereas the proper way is there is a traction the suction is pulling this tissue down, but the dissector should be using a counter traction and dissecting the nerve away from this. The site and size of the incision. The site should be properly planned, especially when you use the narrow corridor, and the size also should be adequate. It should not be too long or too small. So this should be adequate for safe and effective removal of the lesion. The primary aim should be to remove the lesion completely, not that the size of the incision should be small, but it should be adequately large enough so that in case the first plan fails, then you should be able to perform the operation with the second plan. For example, if you are planning endoscopic surgery, and if you are not able to perform that surgery, the second plan, that is with the help of the microscope and with the same size of the incision, you should be able to complete the surgery, at least in the beginning of your learning curve. A rotational technique can help relax the hand. In any surgery for any individual surgeon, there is a dominant hand and there is a non-dominant hand. So dominant hand is performing most of the work and non-dominant hand is performing less work. In a longer surgery, your dominant hand may become tired. You should be able to rotate the dominant with the non-dominant. So learn the trick to perform the work with the non-dominant hand also, and try and give relaxation to your dominant hand in the surgery. Bimanual technique should be used because this is the better way of doing surgery. Avascular lesion or a small lesions one can use with single hand, but one should avoid surgery being performed with the single hand. In the bimanual technique, it is better to control when there is a profuse bleeding. It is difficult to control bleeding with the one hand technique. For cutting of any tissue, you require gentle stretching. With one hand, you stretch that tissue and then you cut it. So if you use bimanual technique, it is easier to cut also. And for dissection also, I have already discussed that you require traction with one hand and counter traction with another one in opposite direction for better dissection. Instrument held in one hand should be helping the instrument of the other hand, like the you have dissector in one hand, the suction in another hand. Your suction tip is getting choked, then the tip of the dissector should be able to clear the tissue in front of suction tip and prevent it from blocking. One hand instrument can be used for retraction, the other hand for dissection or for suction, but the role of the instrument can be changed. The dissecting instrument can be used as a retractor, or suction can be used as a retractor, or scissor can be used also as a retractor. And this is the example of how to cut with one instrument. This tissue which is being cut is stressed, and with scissor it is being cut. Everything in the field should be under constant visualization. There should be no blind procedure or a step at all. And this is the example. If you try to pull the tissue, this is the tissue you want to remove, and there may be some vessel or nerve underneath the tissue. So if you want to remove this tissue, you cannot pull this towards the microscope or towards the endoscope. If you try to pull this, then you will not be visualizing the vessel or the nerve which is at the bed of this tissue. And in the process of removing it, you may stretch or tear the nerve or the artery. Whereas if you move it to the side, cranial, caudal, medial or lateral, then you may be able to see the structure at the bed. Introduce instrument at an angle or use angle tip instrument. Retractor arms and blades are curved in such a way that it is lying in close contact with the operating field. It should be resting on surface Otherwise, instruments, cable, or hand of the surgeon or the nurse may entangle with it. Holding arm, if positioned between the operating part and the surgeon, should be close to the patient body to avoid bumping. Retractor blade should be at the highest point and the tightening knob should be lower than the operating area. This is the example. Retracting blade should be at the higher position than the tightening knob. If it is other way, the whole system may accidentally fall inside and cause injury to the brain. The other thing which should be kept in mind that the retractor blades should be curved like brain surface. This should be curved as shown here, curved in the shape of the brain surface, and it should not be curved at right angle. So not like this. The tip may be curved if needed to lift or to retract the brain surface. The other important aspect is the suction, which is quite frequently used. So suction can be used as dissector or it can be used as retractor also, along with its original function of suction. The hole on the suction should be large enough to make suction pressure zero when the holes are open. Suction vacuum power can be regulated by adjusting power in the machine or by the holes on the cannula. There should be larger hole on the cannula, and if it is left open, then the pressure in the suction should be zero. The suction pressure should be mild, just capable of sucking the blood or fluid, especially when you are working near the brainstem, thalamus, hypothalamus, or other vital structures like nerve, etc. Suction tube design should allow surgeons' hand to rest comfortably on the operative margin using a pen type of the grip. Suction tip should be blunt and round. It should not be sharp edged. This might injure the vessel. Angle tip are useful for suction around the corner. Regarding the steps of hemostasis, it could be electrical, mechanical, or chemical. Which I'll not discuss in detail. Patties can be used, which can be held by the assistant to decrease the ooze from the area where surgeon is not working. Keep suction on the patties. You can ask your assistant to keep suction on these patties. So this is the example. If you are working at site C, that is here, for tumor removal, then the site A and B where you have already done work. So you place patties on those areas to decrease the ooze. One should gently retract the patties to the side to see the bleeding point. Gentle stretch on the bleeding vessel by the tubular retractor or by the suction itself stops or decrease the bleeding. Venous bleeding is usually mild, but the brisk bleed could also be seen from venous sinus. So in such situation, keep patties or Surgicel and gently press the bleeding point and raise the head end to control the bleeding rather than going for bipolar cautery. If you bipolar cautery these bleeding point on the sinus, the bleeding will increase. Venous bleeding may be very troublesome. It does not stop by any kind of bipolar coagulation, especially when the intracranial pressure is raised. So in raised intracranial pressure, don't try to cauterize the bleeding point. Best way is to control the raised pressure. So decompress the tumor, or in head injury, whatever way you reduce the ICP, the bleeding usually controls very easily. In epidural bleeding, it can be controlled by either dural hitch stitches or other method which cause close approximation of the dura with the bone. One can use curved dural dissector which presses the dura against the skull bone and the bleeding stops. Arterial bleeding or more brisk bleeding should be stopped first compared to minor ooze when there are multiple bleeding or oozing. Regarding the drilling, it can be done by cutting or diamond burrs. Adjustable turning direction and different revolution per minute is helpful. Diamond burrs are vital for drilling near the important soft tissue structures. Make one loop of the tube around the forearm, hold it like a pen. Use light painting brush like action. Stabilize hand. The hypothenar region of the hand should rest on the skull or other operating part, and the elbow should also rest on armrest or any other part. To and fro motion or side to side movement of short distance is advisable. The drilling direction should not be towards the vital structures. Do not use force against the bone to be drilled, and one should go for axial drilling and leave little bit of thin piece around the vital structures, which should be removed by the micro instruments. The drilling direction should be in the cranial, caudal, medial, lateral, or away from the cord or the vital structures. One should not drill towards the vital structures, or you can go away from that structures but not towards the vital structures. Angled hand piece should be used to work in the depth. Drilling should be done in pulses. Remove dust or wash in between the drilling. Use bone wax or use dry diamond drill to stop the bleeding. Drilling should be done from the side of the burr rather than from the tip. Use diamond burr at the low speed for tactile control near the vital structures. Drilling may cause injury by the direct trauma or by the indirect injury by the heat. Copious saline irrigation therefore should be done to prevent this thermal injury. Acquire skill in the lab before going to the actual live surgery. Observe experienced surgeon before using it in the operation. All covering such as patties should be removed when you start drilling. The entry of bone dust in the subarachnoid space or surrounding brain parenchyma should be prevented by use of rubber gloves, a wet Ab-gel, or flat bone wax. The surgeon should know everything about the microscope, details about the different functions such as illumination, magnification, eyepieces, setting of IPD distance, the balancing, etc. should be known. The bony removal should be done in the steps to prevent dural tear. It should not be done in a single jerk. If you try to do it in single jerk, and by the way, if the dura has been caught in the jaw of the Carrison punch, then there will be a large dural tear. So do it in steps, not in a single jerk. And the steps are: separate dura from the bone, take the bite, release the bite, partially withdraw the Carrison punch, gently hold the proximal part which has been detached from the rest of the bone. And then that detached bone should be removed by displacing it with the foot of the Carrison punch. So gently displace it away and then catch that bone and take it out. The training is the important component of any microsurgery. So this can be done by observing the surgery, attending the live operative workshop, watching the operative videos of the expert surgeon, visiting other department, and observing a skillful neurosurgeon. You can learn these skills by practicing in lab, using cadaver or animal model or the other models, artificial models. You can use simulators. So the basic microsurgical training should be done under high magnification, and one can use simple things like capsicum or papaya for dissection or cutting. The various technique which can be learned are using deep operative area, superficial operative area. You should learn suturing using surgical gloves or elastic tubes. Dissection can be learned as shown here. The hemostasis model can be prepared and you learn how to do hemostasis. The cutting using surgical gloves or the tube can be learned. Inexpensive training lab can be made for training of a young resident using simple inexpensive microscope. One can create a superficial area for training and also create deep area for training using narrow, rectangular or round plastic tube, and at the depth of these plastic container, one can keep the different material for dissection, separation, cutting, etc. So training, creating a deep area can be done using inexpensive model. We have devised an inexpensive practice model for skill development in endoscopic surgery. In this, there is an earthen pot and the hole is made on back side of this port. We attach the light source and the commercially available camera is attached on the back side of this. This port is fixed, and then through this hole various endoscopic procedure practice can be done, such as hand-eye coordination using rubber ring, which is picked from one place to another place without touching the pins. So hand-eye coordination is practiced like this. Then in the other model, one can practice cutting on rubber glove on a desired site which is marked with the pen. Practice cutting is possible using these inexpensive model. The other thing which can be practiced is the laminectomy. For this, ice cream stick is used and marking is made on the ice cream stick, which is also fixed, and then using a Carrison punch, lamina can be removed on the desired point. Various training material can be surgical gloves, elastic tube. You can use animal bottles. You can use mannequin head, the human skull cast model, microvascular anastomosis can be done, knot tying technique can be learned, use microscope, close the craniotomy. Indigenously made inexpensive model can be used to cut the cost. Comparatively less expensive microscope can be used in resource constrained situation for training. The skill can be learned by observation alone or the observation accompanied by the verbal guidance by the expert, and one should remain active because the skill may gradually lose when you stay inactive for some time. The simulators can be used to enhance the education and elevate proficiency level. One can use 3D models for teaching brain anatomy, and ventriculostomy, catheter placement can be done, craniotomy in trauma, resection of the convex T meningioma, minimally invasive spine surgery, endoscopic nasal navigation with micro dissection, endoscopic and endovascular simulations also are available. Spinal dura mater repair can be done. Silicone vascular model for diagnostic angiography have been used as a simulators for training. Although extensive theoretical teaching program is made for a neurosurgeon, there should be more emphasis for practical skill training. Precision or pen grip should be preferred for better precision and to avoid fatigue. If power grip is needed, pen type of the grip should be added to improve precision. Quiet hand technique using intrinsic muscles of the thumb and index finger should be practiced with hand well supported. Body parts should be in comfortable position. Long length instrument also should be supported by other hand or on the operative corridor. Instrument should be as short as possible in the length, angle tip, bayonet shape, round shaft, single limb, and two functions can be added in one. Surgical trajectory should be in long axis of the tumor and 90 degrees to the floor. If capsule is not separating from the surrounding tissue, most of the time it is due to the thick capsule. Decompress it further, remove more tissue, it will be easy to find cleavage between the tumor capsule and the surrounding structure. Movement using rotation is better than the linear movement, especially when you are working in a narrow corridor. Gentle traction and counter traction in opposite direction is needed for dissection. Bimanual dissection is needed for control of bleeding, cutting, and tissue dissection. Retractor arms and blade of the brain retractor should be curved in such a way that it is lying in close contact with the surgical field and should be resting on the skull surface. Retracting blade of the brain retractor should be at the highest level and the tightening knob should be at the lower height. Hole on the suction should be large enough to make suction pressure 0 when hole is opened. Suction pressure should be mild, just capable to suck blood or the fluid, especially when you are working near the brainstem, thalamus, hypothalamus, or other vital structures like nerve and vessels. Hands should be stabilized and hold drill like a pen. Use small to and fro motion in a light paint brushing action when you are using drill. Entry of the bone dust in subarachnoid space and injury to the adjoining structure should be prevented by use of rubber gloves, wet Ab-gel, and the flat bone wax. Separate dura from bone, take bite, release and partially withdraw. Gently catch proximal bone and remove bone by displacing this with the help of Carrison punch foot. Observing live surgery, watching operative workshop and videos, visiting other department and observing skillful neurosurgeon, practice in the lab using cadaver, animal models and other models help in improving surgical skill. You can refer to our articles for detail. Thank you very much. Thanks.